The resmetirom. This is the only drug at present FDA has been approved for reversibility of the fibrosis. Diabetes, my suggestion to all of you, fasting blood sugar will be the key factor and HbA1c. If you are going to keep that one, we can avoid MASLD, because what the people's concept, if you are having more and more the fatty meal, they will get the fatty liver. That's wrong. The fatty liver, if you see, patient will not die due to the fatty liver. Most common cause of death will be cardiac death. All the fatty liver groups, they need extensive cardiac lifestyle modification. Simply I can say regular walking. At present recommendation is 20 minutes walk.
Okay, any high fructose will finish your liver, especially corn fructose. And if you take Coca-Cola or Pepsi-Cola, 56 grams, you know why they add phosphoric acid in the thing? Because if you put 56 grams sugar and drink, you will vomit. So you are supposed to vomit Coca-Cola. To prevent your vomiting, they add phosphoric acid. I will tell you in 1 minute if you don't want to go to Dr. Joy Varghese. Check your gamma GT, check your ALT, AST, add all the three. If it is less than 50, you don't need his number.
Ladies and gentlemen, next up, we are going to bring in a wonderful doctor on the stage. The liver is one of the hardest working organs in the body, quietly carrying out hundreds of essential functions every single day. Yet today, liver disease is emerging as one of the fastest growing health challenges across the world. Helping us understand this evolving landscape, particularly in the era of MASLD and MASH, is Dr. Joy Varghese, a globally respected hepatologist and liver transplant specialist with over 15 years of experience. His expertise spans fatty liver disease, hepatitis, advanced liver disorders, and liver transplantation. He is also recognized for pioneering advanced interventions for complex liver conditions. With more than 1,500 successful liver transplants, including pediatric cases, he has played a significant role in advancing liver care in India. An award-winning clinician, researcher, and educator, he has established liver transplant programs and mentored specialists across the country. Through his work in patient care, innovation, and medical education, he continues to shape the future of liver health. Ladies and gentlemen, please join me in welcoming Dr. Joy Varghese. Give it up, everybody.
At the outset, my sincerest thanks to Siva sir for the kind invitation to me. So the next 20 minutes, so I'm going to talk about the liver and the metabolic disease. Liver we all know, but the metabolic disease, how it comes into the liver region. So we all know the metabolism means which is giving energy to our day-to-day life. Whatever the activities we are doing, exercise and the sleeping even, that all we need energy. From where the energy is going means from our food. So once if it goes into the gut, if the gut is normal, through the portal system, it goes to the liver. If the liver is normal, it will do all metabolism, carbohydrate, protein, fat, and minerals, storage, vitamins. And these metabolites goes giving energy to all other organs, brain, kidney, heart. Even if you are going to take some medicines due to the various disease, as a doctors we all know, so that either the tablet form, it will go to the first liver, even though it's a brain related or the kidney related, heart related, it will get metabolism, the metabolite will go and act. There are exceptions. which will cross into the systemic circulation without liver. For example, for the sublingual nitroglycerin, if we give, it won't go to the liver. Directly will absorb into the systemic. Same way, the rectal, the suppositories or the painkiller, it will no need to go to the liver. It will absorb into the systemic circulation. Even we are giving IV injections for any disease, it will go through the liver, metabolite will get. So, the liver, without liver, all the other organ, normal function will get disrupted. If particular level goes to some disease, so far during our graduations in the earlier times, we used to talk about viral hepatitis, autoimmune hepatitis. Metabolic means always they will talk about Wilson disease, hemochromatosis. That means that kind of the knowledge, it was there. But now, the metabolic liver disease is not only the viral or autoimmune or the Wilson and everything, it goes to the fatty liver. MASLD, metabolic dysfunction associated steatotic liver disease. Such a lengthy the structure, we are calling it a MASLD. 10 years before, no one knows about that terminology. Even in our scientific conferences, we have not at all used this type of terminology. But now, this terminology is common in cardiology conference, diabetologist conference, IMA meetings, most of the things. So, the concept is keep on going, metabolic dysfunction. If it happens, that will cause steatotic liver, the fatty liver. That fatty liver is not a normal, it is a disease. So, the metabolic dysfunction associated steatotic liver disease is the common terminology, and unfortunately, most of us, not only the worldwide, this is now comes as a epidemic region. It is not the disease which comes from the virus or the genetic. Genetic will play a role, I will show the future slide. But it's not a major contribution. This all happened due to the lifestyle and this diet related. So I have mentioned here MASLD cirrhosis. We all know cirrhosis means irreversible liver damage. So the metabolic dysfunction related the fatty liver at one point makes the liver into irreversible damage. That irreversible damage groups only going for liver transplantation. In our center, normally we are doing 100 plus liver transplant in a year, but in the 2010, if you look into the data, alcohol related liver cirrhosis was the number one. I have not noticed metabolic associated, the dysfunction associated steatotic in our data. But if you look into our previous year, 2025, almost 100 means 55% of the transplant is due to the metabolic dysfunction associated. This comes first, not only in one center, across the world. So they are projecting in 2030, this will be the leading cause of cirrhosis. And if you look into that, the resmetirom, I will give some more detail later on. This is the only drug at present FDA has been approved for reversibility of the fibrosis, not in F4. Fibrosis, there are 4 stages. F4 is called cirrhosis. F1, F2, F3 are the beginning. If we use the drug either in F1 stage or F2 stage or F3, the maximum duration they are mentioning 1 year, it's reverting back, not completely normal. From F3 to F2, some people F1, from F1 groups will go to F0. So that is the only drug at present approved. There are the multiple drugs are in pipelines. So my next speaker will talk about what are the newer drugs for that MASLD. So here We all know what are the risk factor involving means fatty liver can occur in diabetic groups, fatty liver can occur in the obesity groups, sometimes fatty liver occur even without obesity, without diabetic also, if they have the other components of the metabolic syndrome. So we know the components of the metabolic syndrome. Hypertension is the one of the component. Hypertriglyceridemia is the one of the component. Low HDL is one of the component. High LDL is one of the component. And the insulin resistant. Other than that, nowadays they are noticing in the female polycystic ovarian, PCOD. So that they thought it is an incidental finding, but it's also be the one of the component. So there are so many, the components are involving to develop the disease, but we have to understand in our patient which component plays the major role for this MASLD, the particular component related medication, lifestyle modification, everything we have to suggest. Again, in the more or less, the components wise I am telling, if you look into that, diabetes, my suggestion to all of you, fasting blood sugar will be the key factor and HbA1c. If you are going to keep that one, we can avoid MASLD, because what the people's concept, if you are having more and more the fatty meal, they will get the fatty liver. That's wrong. If you are going to take more and more sugar, carbohydrate, we all know the carbohydrate component, glucose will go into the gluconeogenesis and it will convert into the fatty triglyceride component and it will stay within the hepatocyte. So high carbohydrate, that alone is sufficient to cause. That's why the vegetarian groups, usually they will ask me, so I am vegetarian, why I am getting the fatty liver? Because more and more they are taking carbohydrate, excessive carbohydrate within the liver, it's converted into the triglyceride. The triglyceride initially will be in the cell as a inert. It will not cause any injury to the liver cells. But once the deposited, the triglyceride quantity is keep on increasing. First will be a 5%, then 10%, 20, 30. Once crosses 70% and other thing, the rest of the cellular normal hepatocyte will get so many mitochondria, Golgi apparatus, whatever. Each one will do so many function. In our biochemistry, we have read lot. All the cycles has been destroyed because of the excessive deposit of triglyceride component within the cells. So at one point, our body immune system will think it is the foreign body. So the neutrophil, lymphocyte, everything start to affect the triglyceride loaded, the fat cells, the hepatocyte cells. That's why it's going for inflammation. That time if you do biopsy, it will show neutrophil infiltration, lymphocyte infiltration. That inflammatory infiltrate will release so many cytokines, so a destruction of the cell. So our body immune system trying to protect, it is thinking this much loaded, the fat loaded component is not good to our body. So that inflammation over the period of silently it is progressing. That time it causes fibrosis. It will be stage 1, that's why I mentioned F1, F2, F3, F4, then cirrhosis, then it goes to irreversible. So simple mechanism of this, the pathophysiology is starting at our diet level and our sedentary lifestyle. So this kind of the concept, initially they thought, they are not studied much. They thought 2 group of fatty liver. One is the alcohol, the toxin alcohol will cause fatty liver. They will label it as alcoholic fatty liver because we know alcohol, acetaldehyde, that is causing. Other group they thought teetotaler, NAFLD, not MAFLD. Initially it was called as NAFLD, non-alcohol. But now we know it is not due to non-alcohol, it is totally due to MASLD. metabolic dysfunction associated steatotic liver disease. So these are, so if you take the component, we all know. So initially it was MASLD, simply label it as a, if you go through our previous books, medical books, even the literatures and journals, everywhere will be the NAFLD epidemiology, NAFLD pathophysiology, NAFLD treatment. Now, there is no NAFLD, mostly going MASLD. Advantages I already told. The awareness has been gone beyond the limit. Whenever the NAFLD, the era, only hepatologists in the liver conference or gastroenterologists in their conference, they will discuss. But now, as I mentioned, diabetologists, cardiologists, IMA, everyone is started, even oncologist, because MASLD is the precursor of the malignancy. At present, they notice it in the colonic. So that kind of the separate pathway. How the fatty liver related, the mechanism act as a precursor of the malignancy. Similarly, if you look into that, the MASLD, most common cause of death is not due to liver failure. That we have to keep in our mind. The fatty liver, if you see, the patient will not die due to the fatty liver. Most common cause of death will be cardiac death. So, all the fatty liver groups, they need extensive cardiac evaluation. That is causing the pathway also, they have been clearly explained, young cardiac death, most of them. Initially, again, they thought it's a coincidental finding. The cardiac versus the fatty liver, it's nowhere related. Now, they have noticed the reversibility of the fatty liver. It is reducing the prevalence or the cardiac disease. So, these are the epidemiological studies already world level published. So, most common cause of death in MASLD is the cardiac failure. So, these all already I have explained little bit, just I can, the nomenclature, adaptation, everything. First of all, we have to know what are the risk factors involving MASLD whenever we are seeing patient, either obesity or diabetes or hypertriglyceridemia, or the low HDL, or the pre-diabetic, or the family history of the patient have the liver problem or heart problem, then we have to try to tell about the prevention related lifestyle modification and the diet. And the lifestyle modification, simply I can say regular walking. At present recommendation is 20 minutes walk, simple walk, not a jogging or running per day. Even out of 7 days, 5 days is more than enough to somehow control. So that is the at present worldwide recommendation, 20 minutes walk per day. That's nothing actually if you look into that. And normally the diet wise, they are mentioning about already mentioned, less carbohydrate diet. So it is challenge to our Indians, particularly South Indians, but we have to start to practice. So mostly the high calorie diets are carbohydrate. So if we are restricting snacks, sweets, and the potatoes are very rich, that kind of items, and the soft drinks, aerated drinks, these all will somehow reduce the fat formation within the liver cells. And we have to go for the regular screening and everything. So normally, how to diagnose the fibrosis nowadays, we have the machine called, everyone knows, FibroScan. So my request to all of you, whenever you are seeing the ultrasonogram report shows fatty liver grade 1, grade 2, grade 3, whatever, just recommend the people to go for FibroScan test. That is nowadays most of the centers available, it will show two values. One is the fat component, another one is the fibrosis score. The fat component value should be there, come as a less than 300. The fibrosis component should be less than 5 kilopascal. So if you this all is very simple to keep in our mind, and whenever you are regularly looking to that, it is a dynamic test. Now the patient's level shows very high. We can advise the treatment, all the the lifestyle modification. Then we can ask them to review after six months. That time we can repeat the FibroScan if the values are very high. But still, then we have to modify the medications. And if the values are coming down, we have to encourage the patient, okay, it's showing the reversibility. So this kind of the screening tool we have to use. These advantages, everything is happened nowadays after the nomenclature. It has changed to the MASLD. So more and more awareness is going on, because most of the people started to do the FibroScan camp in the so many center, I mean the rural area also they are doing. And regarding the medication, I told at present only one drug shows the reversibility of the fibrosis. But there are so many other drugs are there to show the reversibility of the fat component. So fatty liver is the first phase. If you diagnose fatty liver, that is different drugs are available, like antioxidant, vitamin E, and there are the PPAR agonist. So many people are saroglitazar. The saroglitazar, vitamin E, it will reverse fatty liver. It will not reverse the fibrosis. Fibrosis is the end component of the fatty liver disease. For that, at present, FDA approved only one drug is the resmetirom. The resmetirom is a 80 milligram dose once a day. Here, the duration of therapy is important. In resmetirom, we have to give maximum 52 weeks, maximum 1 year. So what about after a year? So they need a discipline for their lifestyle modification. During this 1 year, they have to learn the lifestyle modification, diet, exercise. They have to try to practice that they have to follow. We shouldn't continue the drugs more than. Same thing, the reversal of fatty liver also, the saroglitazar, vitamin E, we shouldn't give lifelong because it's not at all recommendation. So the vitamin E at present recommendation is the 3 months duration, maximum 800 milligram. If you take a saroglitazar 4 milligram tablet, maximum 1 year. But if the saroglitazar advantage, it is a lipid lowering drug. If our patient have the associated dyslipidemia, they have the high triglyceride in the blood level, not the fat in the liver. If in their blood level they have the dyslipidemia, the saroglitazar we can give a lifelong, like other fenofibrate or the rosuvastatin, all other the lipid lowering drugs. So we have to learn not only lifestyle modification and the risk factor we have to correct it, at the same time which drug will be suitable and how long we have to give to the patient also, we have to know that. So I told about the importance of the fibrosis and how to diagnose the fibrosis, FibroScan important, and how to revert back the fibrosis. And here I wish to highlight one point, not only cirrhosis, the fibrotic cell in the liver, one time it will change its component into the malignancy. That's why the MASLD groups, the liver cancer incidence also nowadays coming high. Earlier it was the hepatitis B virus and other thing, and now it's a thing. So time is out. So just I am going to the key messages. Ladies and gentlemen, the MASLD, the nomenclature change, importance, I insisted how it will be there. We have to identify the risk factor, all the risk factor of our patient. We have to take a corrective measures. Along with that, lifestyle modification, exercise, diet, practice is very important. Needy groups, we have to start the therapy and we have to know how long we have to give therapy. And most common cause of the fatty liver groups are dying due to the cardiac disease. So we have to refer the case to cardiologist. And the other thing, the family history, I mean, we have to screen for malignancy, because nowadays we are seeing more and more liver cancer as well as the colon cancer in the groups. Thank you so much for giving the kind opportunities.
You know, while doctor is here, he explained what medication, but I will tell you in 1 minute, if you don't want to go to Dr. Joy Varghese. Okay, check your gamma GT, check your ALT, AST, add all the three. If it is less than 50, you don't need his number. Okay, any high fructose will finish your liver, especially corn fructose. And if you did take Coca-Cola or Pepsi Cola, 56 grams. You know why they add phosphoric acid in the thing? Because if you put 56 grams sugar and drink, you will vomit. So you are supposed to vomit Coca-Cola. To prevent your vomiting, they add phosphoric acid. Okay? And then there is a shortcut. 5 days do fast mimicking diet. 800 calories, including vegetarian, non-vegetarian, low protein, 5 gram of glycine. Because your body needs 13 grams of glycine, it produces only 3 grams. You take a glycine 5 days, then also you don't need to see Dr. Joy Varghese. If you don't do that, please see him. He is the best doctor.